Greetings.
Good afternoon, Dr. Matabe.
How are you?
I'm all right. How are you?
I'm very well, thank you.
So nice having you.
It's good to
Um,
finally get to do this.
Welcome to Apile Communications, and
Thank
we're
you
very
very
grateful
much.
to have you on our screens, and I'm sure our viewers are thrilled. It's unbelievable that I've actually landed a female urologist to our screens. I'm very grateful to God. People think
Thank you
urology
so
belongs
much.
to males. Thank you so much.
Right, no.
Um, Can I welcome and greet all our viewers? I see the numbers are actually escalating as we're talking. Can you take time to greet them before I introduce you formally?
Hi, everybody.
Welcome to everyone to this interesting topic today. Our guest today is Dr. Homotso Matabe. Is a specialist urologist practicing at Steve Biko Academic Hospital. She completed her undergraduate training at the University of Pretoria and then her internship and community service at Johannesburg General Hospital and then OD Community Hospital, respectively. And then after the 6 month, following the 6 month rotation in the intensive care unit at Chris Hani Baragwanath Hospital, Dr. Matabe went on to United Kingdom, where she spent 18 months. And then she returned to South Africa to enroll for urology training at the University of Witwatersrand. In 2011, she became the first woman to qualify as a urologist. In 2011, she became the first woman to qualify as a urologist from the University of Witwatersrand and the second black woman to qualify as a urologist in South Africa. She is number 2 black urologist woman in South Africa and the first to come from Witwatersrand University. And then Dr. Matabe's spectrum of urology uh, includes special interest in prostate cancer and urinary incontinence. So it is not an accident that she will be covering a topic for us on incontinence that has to do with the control of urine. She took a post as a head of unit at Steve Biko Academic Hospital in 2016 and is currently the acting head of department at the Department of Urology at the University of Pretoria and Steve Biko Academic Hospital. So he's occupying 2 positions. That is very nice and fortunate. She has previously headed andrology and male infertility clinic, andrology and male infertility clinic at Steve Biko Academic Hospital and is currently co-managing the Urogyne unit with Dr. Frans van Wyk of Pretoria Urology Hospital. Her work at Steve Biko Hospital allows her to indulge in her passion of teaching undergraduate medical students, which she does as well the registrars, that is people who are studying to become specialists also in urology, andrology, and she serves on the council of the College of Urologists in South Africa as an examiner also at the colleges of medicine of South Africa in urology exams. It means if I were to take a step up, I would meet you as one of my examiners. Very interesting.
Possibly.
Dr. Matabe also serves on the Prostate Cancer Foundation of South Africa. So that is a very huge profile. I'm very humbled and honored to actually host you on our screens as Apilo Communications, and I hope our community of listeners and viewers will learn a lot from you today. Dr. Matabe, let's get started. What's the difference between urology and gynecology? People tend to associate, to confuse the 2 things. Let's just clear the turf first. Urology versus
Yes.
gynecology.
Sure, sure. But before I start answering, thank you very much for that wonderful, warm welcome. I really appreciate that. And for the invitation. So one of my passions is definitely community education. And I've been speaking a lot to the undergraduate students because we give them tutorials as well. And I've been saying to them, it doesn't help to have all this knowledge in your head. The knowledge in your head counts for nothing. It's only when we share it with the community, with the people who need to have it, that we're actually doing good work. So thank you so much for the platform to indulge myself in my passion of community engagement and community teaching.
Thank you so much. Our pleasure.
So as to urology and gynecology, there is a definite separation. In urology, we deal with the urinary system as well as the male sexual system. So we do see both male and female patients, although we have probably 90% males. And then the gynaes deal mostly with the female sexual organs. And yes, a little bit of the bladder issues as well. But yeah, that's the big difference. We do urinary system and male genitalia.
I'm very glad that I met you at the Durban conference because I've been interested in you, and I'm very glad that I've finally landed you. I looked at your profile and I see that you've done a lot of work on infertility, on andrology, which is the infertility issues in males. And I do a lot of talks for SABC Radio, True FM, and the Umhlobo Wenene, and I stick to most of those issues, andrology, infertility, both in males and females. Was it easy, or is it an easy task for a female to handle the male organ? Because I imagine...
You know what? I do get that question a lot. And I think when people need help, they will go to whoever will offer them the help. And obviously we understand that the work that we do is of a very sensitive nature, and we address it in such a manner. But if people really want help, they'll take the help from whence it comes. And I've never really had to deal with male patients who have an issue with being seen by a female, but I think that's because those who do have an issue are never going to end up on my doorstep. So I'll never know if there is anybody who's got an attitude or an issue with me, because the only ones I see are the ones who need help and want help and are willing to get it from me. So it's not really been a thing. If you have an issue, I won't ever know about it.
That's very great to hear from you, because at Appeal Communications, we're dealing with gender stereotypes, we're dealing with myths and stereotypes. So it's very good to have a female specialist who's actually in a male-dominated specialist field. And I'm very glad that you are handling this so well. Because even in medical school, we used to have issues when a female had to examine a male private organ. And we used to sneeze and laugh and so on. And now to have a specialist in that field is encouraging. What can you say to other females, even before, this is a Women's Month, what can you say to them, just even before we get started with today's topic, to encourage so that we see more of females in the field of urology?
I probably don't even need to say very much, because most of the interest right now, a lot of people who are looking for registrar posts, who are inquiring about specializing in urology, are mostly girls. So I think they've already dealt with the issues, whatever they are. But I would just say, for me in medical school and undergraduate training, I had a lot of fun in pathology. So in the first 2 years, I thought I would probably specialize in anatomical pathology. And then as we went along and started with the clinical work, I really enjoyed urology and orthopedics. So I was either going to be an orthopod or a urologist. And then when I was in the UK, I spent time in an orthopedics hospital, and I really, really hated it. So then the decision was made. So I think people must just follow their passion, that which you enjoy, that which is fun for you. That's what you must do. And we really should get over the gender issues now. Although I often say tongue in cheek, look, I am the answer to all the male gynaes. There are so many male gynaes. I'm like, you know what? I'm just rebalancing the scales here.
It's very interesting that so many gynaes are actually males. It's very interesting. So it means more males are interested in studying the female structure, and so few women. I'm very glad that there's a woman who's actually has got an interest in doing the opposite. You've actually, you've done a very tremendous job. Can we get to today's topic? The urinary system. We're talking bladder issues.
Yes.
How common is the problem of urinary incontinence in females?
It is very common. So unfortunately, you know that our research efforts in the country are not very good, not very well supported. It's definitely an area in which we're deficient in. But at UP, we're working very hard to try and fix that. And I think actually all the medical schools around the country are really, you know, we have a lot of, the patients that we have provide an amazing platform to engage in Afrocentric research and to actually be able to answer the, you know, global North America and Europe. You know, all the stats that we always quote here at home is always stuff that's done elsewhere. So it's time to start fixing that. So that is definitely another area of interest and passion for me. But we see it commonly enough. But I suspect even if we had the statistics from the hospitals, that would not be a true reflection. That would not be a true reflection of the prevalence of the condition. How common is it? Because just like men are terrible at seeking medical help, you know, you got to be tough and, you know, you live with things until literally a patient is dying from this. Only then do they come and see us. But there are also certain things about how females do things, and that we also try and just manage. So, and especially the things that are not life-threatening. So if you're incontinent of urine, meaning you can't control your urine, and there's various ways in which this happens, but people just learn to live with it. You know, they make a plan, they make means, you know, they wear more pads and they wear diapers, and, you know, they contract their lives. So then, you know, if you speak to a patient, they'll say, you know, I don't go to church anymore. You know, I don't have family come and visit because they are so embarrassed by the condition, but they actually never really seek help for it. So I'm sure that the prevalence of the condition is far more than what we see in the hospital. But I mean, we run a urogyne clinic, and we are seeing patients every week with this condition. So it's not rare at all. And it might be something as silly as, you know, just needing to take one tablet a day that might fix the problem, or it might be very serious. So it is something that people really should seek help for.
Wonderful. Can you define incontinence in simple terms? What is incontinence? Urinary incontinence
Sure.
for someone who's on the street.
Sure. So at the bottom of the bladder, we have an organ called the sphincter, which is basically like a gatekeeper for the bladder. And what should happen is that throughout the day, your bladder fills. I mean, our bladder is filling more than 99% of the day. There's only two main functions of the bladder, and that is storing urine, and that is more than 99% of the day, and occasionally expelling urine, releasing urine from the body. And that is less than 1% of the day. So, and that process should be voluntary, to the extent that during the time that the bladder is filling, so 99% of the day, you should actually not even think about the fact that you have a bladder. It must do its job quietly, silently. It must not even alert you to the fact that it is working. And only when it is full, when it has reached its capacity, it must then communicate with the brain to say, okay, I need to empty. And you need to have the control to be able to say, I understand that, but now's not a good time. I'm in the middle of an interview. I'm in the middle of, you know, traffic. And you need to be able to tell your bladder, now's not a good time. And it must actually listen. It must be able to listen. And so what sometimes happens with some people is that when the brain says to the bladder, now's not a good time, we're in the middle of an interview, that the bladder does not listen. So the bladder contracts and expels urine at any time, unprovoked, unpredictably, and that's what causes the great distress in people's lives. So that's the one form where it does store urine, but occasionally it just expels the urine without your voluntary control. But some patients have got incontinence that is constant all of the time, that they're leaking and they're wet, you know, every single minute of every single day. So there is that way of presenting as well.
That's very nice and simple. So, in other words, you say we've got an unruly bladder, a bladder that does its own thing.
Absolutely.
It's
We actually
defiant
call
protocol.
it we call it an overactive bladder. So, you know, like that child with ADHD who just won't sit still. That's what this bladder does.
Thank you so much. We've got the upper urinary tract system and the lower urinary tract system. Can you just go through that for us so that we understand the process very simply? You mentioned the blood, the sphincter. so that we understand the structure of the urinary system. You've done it so well.
Sure. So the upper urinary tract consists of the kidneys and the ureters. Now, the ureters are the tubes that drain the kidneys. So urine is made in the kidneys, and then it needs to be transported down to the bladder where it can be stored until a convenient time for you to then go and empty. So, and the two must function in a synchronous fashion. So if the and then the lower urinary tract then consists of the bladder and the urethra. So the urethra is then the tube that empties the bladder and allows urine to be released from inside the body. That's then the urethra. And there's one of that, and there's two ureters from above. And then maybe if I can go back to the types of incontinence, sorry, I should have mentioned something there. So the one that I described is an overactive bladder. That is more common in females. It most certainly can happen in males, but it is more common in females. It is more common in females as we get older for a whole bunch of reasons, including estrogen. So in the postmenopausal woman whose estrogen levels begin to drop, that could be one of the triggers for an overactive bladder. But people normally will monitor themselves. They kind of know what circumstances might help provoke that. So some people will say in cold weather, or if they've had caffeinated drinks. So you can monitor yourself and see what are the things that might be contributing to this. So that's one form of incontinence. However, there's another form called stress urinary incontinence. So the first one is urgency or an overactive bladder. The second one is stress urinary incontinence. And with stress urinary incontinence, this also is almost exclusively in females. And that's when there's an increase in the abdominal pressure. So any pressure in the abdomen gets transmitted or transferred onto the bladder. So if we cough, there's pressure that's transmitted onto the bladder. So any increase in the abdominal pressure then causes a urine leak. So patients will say, if I cough, if I laugh, if I sneeze, then there might be a little bit of urine. But that's the better version. I mean, there isn't a good version of incontinence to have. But the stress urinary incontinence is certainly the better version because that's predictable. They know exactly what provokes. If somebody tells a joke and they know they're going to laugh, they know they're going to have a little bit of an accident. So they can predict that. And also it's small volumes of urine that are released that way. Whereas with the overactive bladder or the urgency incontinence, it'll be the entire bladder contents. And that is normally unprovoked and unpredictable. So that's the other type of stress urinary incontinence. Patients will say, if I laugh, cough, sneeze, then I have an accident.
Laughing, coughing, sneezing, and then you've got bits and pieces of urine that come out. That is very common, and it affects a lot of women. What are the main causes of stress incontinence or edge incontinence, if you can touch on those in females?
Sure. So with stress urinary incontinence, one with the increase in abdominal pressure being transmitted onto the bladder, typically those are women who have had multiple births and deliveries. So that's definitely, we know, a risk factor. So beyond the second baby, we know that there's an increased risk of future stress urinary incontinence. Any abdominal surgery and pelvic surgery, so women who've had hysterectomies, down in the pelvis, at the bottom of the body, the organs there fit like a 3D jigsaw puzzle. So everything fits nicely and has got its own certain amount of space. And if there is any disruption with the arrangement of those organs. So one most common disruption would be with a hysterectomy. So if you then remove the uterus by doing a hysterectomy, then the support that the uterus was providing, the ligaments that were in place have now been disrupted. So that we know increases people's risks of having stress urinary incontinence. And then things like obesity. Obesity really is something we need to be addressing very definitively and deliberately. Obesity is a risk factor. Smoking is a risk factor. Anything that makes a person cough chronically, so uncontrolled asthma, bronchitis, those kinds of things will contribute. Constipation, something as silly and stupid and silly as constipation can contribute to that. So we all need to be making sure we're managing our bowels regularly and managing our bowels correctly. So there's a few things, especially with stress urinary incontinence, which we can control. Yeah, so there are things that we can do to avoid surgery. So if people know that and can actually then, determine a program of conservative management, as we call it, so where we're not operating, we're not giving you tablets, but just some lifestyle changes might be all that's necessary to deal with that problem. So not everything has to be fixed by taking a patient to theatre.
Thank you so much. You mentioned quite a few things on the causes. Let me just pick one. Alcohol. There's a tendency for people when they drink alcohol and then they wet themselves. Is that part of incontinence?
Not really. The only way that alcohol would contribute is that we know that alcohol is a diuretic, meaning it makes
Yes,
you make
definitely.
more urine. So you're going to be producing more urine, not just from the fluid volume that you've taken. So you make more urine than of the alcohol. So it's not just a volume for volume thing. So yes, there's the volume that you've taken, but it's actually got a diuretic effect. It makes you make even more urine. So what that'll do is just fill up your bladder more. And so if your bladder's filled more, you're going to need to go and pee more. So, but it does not contribute towards a causation of either stress urinary incontinence or urgency incontinence.
And
But it's
then
bad
the
for so many other reasons. Causes other problems, but not
definitely,
incontinence.
it is common to see people wherever there is alcohol, then they keep on going to urinate and so on. But you've put it very clear, alcohol is a diuretic. And as someone who has worked in
That's right.
andrology and fertility issues, what impact does alcohol have on those issues? Just to divert a little bit.
Sure. No, it does have an impact. I mean, andrology and infertility is a very complex issue. But the problem with alcohol in that space is more in terms of the erectile function. So not necessarily about the quality of the semen, but it is the impact of alcohol on erectile function, and the impact of alcohol on as a cause of vascular disease. And we know that vascular disease is a big cause of infertility and contributes to infertility and erectile dysfunction. So anything that messes with the vessels is a problem.
Thank you very much. I'm glad to get that from a specialist, a top specialist, because there are a lot of people who think that when they drink alcohol, they get delayed ejaculation and they get stronger in bed. I'm very glad that you are saying that alcohol messes with your blood vessels, it messes with your blood circulation and nerves and so on, and it eventually causes erectile dysfunction. That is very clear. And then let's go to the issue of childbirth. You say the more multiple pregnancies you have, and the more you deliver naturally, higher the chances of getting incontinence. Is it because of our recklessness as doctors, or is it something that we should expect because of the trauma? Why is the childbirth a
Yeah.
problem?
Yeah, no, unfortunately, it is something that we can just expect under normal circumstances. So I've been asked before, is it about the natural delivery? Is that where the problem lies? And if so, could one then decrease your chances of getting stress urinary incontinence by having an elective cesarean?
Yes.
That would definitely take care of. But no, it doesn't. Because, like I said earlier, one of the contributors is obesity. So if the pelvic floor is meant to carry, 10, 20 kilograms, and you're putting twice as much on it, that is where obesity causes stress urinary incontinence. And so too with a pregnancy. So you can't carry a baby for 9 months and think that just by quickly having a cesarean section, then you're missing out on the potential complications. That weight has been sitting on your pelvic floor for all that time. So it does not negate the possible stress urinary incontinence. But there are things that women can do to try and prevent this. And I mean, it sounds, I mean, we've all heard about Kegel's exercises. And I'm not sure how many women actually bother to do them when pregnant, but certainly Kegel's exercises, anything that one can do to strengthen the pelvic floor prior to delivery certainly helps. But if you like a prolonged labor, difficult delivery, if we're having to use instrumentation. So if we're using forceps or, a vacuum to deliver the baby, then we are definitely increasing the possibility of stress incontinence for sure.
The issue of age. You say it's natural and expected that as a woman ages, there's an issue of menopause, which houses a lot of estrogen, and estrogen is very good at supporting the urethra and so on. Can you just expatiate on the difference between a female urethra and a male urethra?
Sure. So first of all, the length, yes, the female urethra is definitely shorter. So we're talking about a 3 to 4 centimeter long structure. And also the continence mechanism of females is different to that in males. One very big difference being that, of course, males have a prostate. So that's another 3 or 4 centimeters of a structure that helps with closing the urethra. So protecting against urinary leaks, and that's a structure that women do not have. So just the anatomy is very different.
So women do not have a prostate at all?
No, we do not have a prostate at all. We do have organs which are residual. So I mean, it's not even organs. They're little glandular structures which come from what would have developed into the prostate if the person had developed into a male. But yeah, so women do not have a prostate, and so we don't have that extra mechanism of helping with continence.
So
and that's where the big difference is.
Men have got an advantage because of the prostate. The prostate supports the urethra, so it actually assists in terms of control of urine. So that is why statistically more women have got this problem of incontinence compared to males.
Absolutely. Yes. And then maybe on the topic of the estrogen and postmenopausal. Absolutely. Estrogen is very good for quite a few things. And within the urinary tract, it supports, so within the urethra, it causes a nice bulky urethra. It causes increased blood flow to the urethra. So you've got a nice bulky structure. It increases mucus production. So in the middle of the urethra, there's normally a mucus plug that also helps prevent incontinence. So with the loss of estrogen, you have less blood that supplies the urethra. You have a thinning of the thickness of the wall of the urethra, and you have a decrease in that mucus production. So all of those contribute towards making urgency or overactive bladder more common in women post-menopause.
Thank you so much. I understand the bladder is made up of a smooth muscle, the detrusor muscle. And you mentioned overactive bladder is the most common problem with females. What are the main issues? I'm looking at solutions now. If we identify the problem, then we look at the solution. Why are women suffering from such an overactive bladder?
So we don't know for sure. We've got a couple of theories. Is it based on the inner lining of the bladder? Traditionally, and historically within medical training, the inner lining of the bladder was just seen as just, nothing really, just a lining, but it is actually a very active participant in the regulation of urinary function. So the inner lining of the bladder has multiple functions that contribute. So anything that causes irritation of that lining, and that can be in the form of, in people who smoke, some of the metabolites of smoking end up in the bladder, and that can cause irritation. Caffeinated drinks, so caffeine is a definite irritant to the lining of the bladder. Women who have had recurrent urinary tract infections, all of that irritates the bladder. So the one theory is about the lining of the bladder that might be a problem. The second theory is about the nerves. So the nerves that supply the bladder wall, that irritation of those nerves might be a problem. And certainly then the next layer is the bladder wall itself, the detrusor smooth muscle, that some dysfunction in that might be responsible. So there's a couple of theories, and they probably all interact together to cause this problem.
Then let's go to the sphincter. There's an internal sphincter and the external sphincter. What problems
Yes.
could actually cause incontinence at the sphincter level?
So at the sphincter level, it's most likely going to be trauma. There's very few other things that can disrupt that. So either direct trauma to the sphincter itself. So we've seen in some terrible car accidents where a patient has sustained a pelvic fracture. That can then injure the sphincter. Surgery, if we're doing surgery, sometimes if you've got, very bad malignancies that are very extensive in trying to get that out. So be it a urology malignancy, be it a gynae malignancy, so uterus and vagina, be it a GIT, so the lower gastrointestinal tract, anal, sphincter. So surgery in the pelvis certainly can cause damage. So either to the sphincter itself, but also to the nerve. So anything that injures the back. So also with car accidents, people falling off of step ladders, women are forever climbing onto step ladders, taking down curtains and doing crazy things. So that can also result in trauma to the lower back and to the nerves. So yeah, with a sphincter it would be mostly injury. And like I said, with the assisted deliveries. So if you're going to be putting in forceps to try and get the baby out, that can potentially injure the sphincter.
Wonderful, wonderful. Then let's come to the pelvic floor. You spoke out about Kegel exercise. Why is the pelvic floor important in control of urine? The pelvic floor muscles.
Sure. So the pelvic floor muscles contribute to the external sphincter. You mentioned earlier the two sphincters, the internal sphincter and the external sphincter, which are the gatekeepers to the bladder. So the pelvic floor forms part, so some of the muscle fibers of the actual pelvic floor interlace with those of the external sphincter. So a strong pelvic floor is definitely a good thing for continence. And that's where, with treatment, one of the things we can do, I mentioned earlier, we can do the conservative measures. So stop smoking, lose weight, let's manage your asthma better, all of those things, decrease your caffeinated drinks. So, but once we've done all of those and the patient is still symptomatic, then another step that we can engage in is physiotherapy. So the pelvic floor physios are an integral part of managing this problem. And in the past, physios needed to do pelvic floor physio as a postgraduate, as a speciality. So many of the older physios had to do it that way. But in the new curriculum, they've actually brought pelvic floor in at the undergraduate level, so that all the new physio graduates will have had some exposure to how to manage the pelvic floor and how to help us manage women with pelvic floor disorders. So the pelvic floor is quite important, and it is a structure on which everything rests. So the termination of the urinary system rests on the pelvic floor. The termination of the female genital system rests on the pelvic floor, and the termination of the gastrointestinal system rests on the pelvic floor. So it is quite an important structure for keeping everything where it should.
It seems you are placing a lot of importance on the pelvic floor muscles. And since they are not only supporting the urinary system, they are also supporting the anus and the rectum and structures around. It means problems within the rectum can also affect, have a contribution in terms of incontinence.
Absolutely. And that's why I mentioned earlier the most common one being constipation. I mean, so like obvious almost, but we don't think about that. So absolutely, in our assessment of a patient with urinary incontinence, we must ask them about their bowel habits. We must find out what is happening with the rectum, GIT. So all of that is important. It is part of the assessment, because we can't just assume that anything that's happening with the bladder is an isolated bladder issue. So we do look at everything holistically within the pelvis, for sure.
Thank you so much, Khomotso. And then there are people who urinate during sleep. We call that enuresis. Is it part of incontinence? People who wet their beds during sleep.
Yes. So typically with enuresis, that we use it to refer to children who have not attained their bladder control at night. And there's various reasons for that and various treatments for that. And it is not normal. So beyond the age of about 5 or 6, this should be addressed. And I know that sometimes culturally or within families, there's certain things which are said to be normal. Had a patient some years back, she was a nurse, and her son was 16 and still wetting his bed. And from her husband's family, this was normal. He said, but all the males in my family have had this problem. And she was very worried. So absolutely, it's not normal. It does need to be addressed. But yes, it can persist into adulthood. And it must be looked at. It must be looked at. So one of the other types of incontinence that we didn't touch on at the beginning, that is total incontinence. So total incontinence are the patients who are wet all of the time. But that history is normally very easy to figure out because that is often related to some kind of intervention, often surgery. So it can be, following a hysterectomy or something like that. So that we normally can trace the history to how this patient ended up here. But sometimes people can have a total incontinence from birth. So where it is something that was there already when they were born, and they just kind of learn to live with it and manage it, but that also must be addressed. But yes, so the people who are continent, during the day, there's no problem with the urination. They've got full control, and yet at night they lose control. That also must be looked at. It can be due to a few various reasons. The most common thing being diabetes. You know what I mean? This could be the first sign that we're dealing with diabetes. So even that must be addressed. Other, rare types of incontinence, there's something called giggle incontinence, which is something that happens in young girls. So they'll be, 13, 14, 15, into their mid-teens. And we haven't figured this one out, which is a very interesting thing, but that these girls, when they laugh, they are incontinent. So it's not the same as stress incontinence. It's not the, if I laugh, cough, sneeze. So if they raise their intra-abdominal pressure by other means, so if they cough, they don't leak. If they sneeze, they don't leak. It is specifically related to laughing. And we're not sure if there is maybe a center in the brain that is actually responsible for this. So there are various other types of incontinence for sure. And whatever type you have, if you cannot control your urine for whatever reason, you need to see a doctor. It's just as simple as that. You know what I mean? So it might be nothing. And if it's nothing, we'll reassure you. But if it is something, then we can actually deal with it. And the problem with a lot of urology conditions, by the way, including something as bad as prostate cancer, something very severe, and a lot of urology things are not going to kill you immediately. So they are more, they have a greater impact on the quality of life rather than them being life-threatening. So somebody with an advanced prostate cancer, you walk into the urology ward, somebody with an advanced prostate cancer can still feed themselves and get around and do things. And if we go to the internal medicine ward, their very sick patients are very sick. So the urology stuff does not look that dramatic. And so it's very easy for patients to just ignore and, just explain it away and that sort of thing. But really, if you can't control your urine, it's a problem.
Then what is the impact of the bladder incontinence on female? Firstly, in their lives, and then on sexual health?
So it does have a big impact because it is, the biggest thing is, like I said, on the quality of life. But quality of life, what does that mean? So one of the patients that I've had in the past was somebody who was a lawyer, and she would need to sit through meetings, for an hour, 2, 3 hours. However, she needed to pee every 15 to 20 minutes. So how are you functional? How are you able to carry out your duties if you need to be in the toilet every 15 to 20 minutes? How are you functional if, you're wearing 3, 4 pads and that doesn't contain the urine? And now you're wearing nappies. I think the impact on self-esteem, your ability to just get around and handle your business on a daily basis, I think is greatly impacted. And certainly from a sexual perspective, how are you going to be with somebody if you're not able to control your urine. If you smell of urine, they might have excoriation of the skin, there might be infection of the skin, and so that might then make intercourse painful. So there's many ways in which this impacts on people's lives, for sure. And I mean, you know, we can't say, oh, it's just little old ladies, you know, who are retired and sitting in the village who are impacted by this and they can just manage it. You know, people who need to work, who need to be functional, who need to be interacting with other individuals in workspaces, in home spaces, are impacted by this.
That's very great. And I'm looking at now stress incontinence or urinary urgency. Is it there's something we call in sexual medicine squatting, and then can it not be confused with bedwetting in the case of females, someone who's struggling with urinary incontinence as opposed to squatting?
I think it can. So that's where then, you know, one of the basic things that, you know, we teach medical students is how to take a thorough history, because there are so many things that can overlap and be confusing. And I mean, you know, how's a patient meant to know? You know what I mean? And they come in like something's happening down there. And first of all, you need to figure out what they mean by down where. You know, there's different organs there. So you need to try and determine what is happening. So what is it that's bothering the patient? And then try and figure out which organ is involved. So it could well be causing confusion between those two.
Then let's come to solutions. Thank you very much. Any solutions for all these troubles?
Sorry, I'm just going to turn this around.
No problem.
So, okay, that's coming off. Sorry. Sorry about that.
No problem.
Yes,
you're welcome.
Solutions start with figuring out exactly what the problem is. We cannot fix something if we don't know what the problem is. And that is just the normal steps in medicine. We take a good history, we examine the patient, and we figure out what the solution is. So it might be like for urgency incontinence, the typical solution there would be a tablet. There's various groups of tablets that we can try, and we can go all the way even to injecting. So Botox that the Hollywood stars are using for their wrinkles and their faces, we can use that same drug and inject it into the bladder. So there's definitely a solution for urgency incontinence. And then there's, you know, operations if necessary, something called neuromodulation. So we can do that. That's more invasive, but the effects are more permanent. But that is done under very specific circumstances. But there is a solution. There certainly is a solution. Then stress urinary incontinence, it might be something as simple as, you know, your regular physio. But if that doesn't work, there's also operations that we can do for that. There's one called the sling or tape. So that's typically the one that we use if we need to go there. If the conservative measures haven't worked, patient stopped smoking, has lost weight, all the other things, we can do surgery. Total incontinence, so the one that I said can happen post-surgery, so after a hysterectomy or something of that nature. That also, we need to identify where the hole is. So it means that there's an abnormal communication between the urinary system and another organ system. So we need to figure out where that communication is, where that hole is, and then close it. And then, so there definitely are solutions, and some of them might be as simple as a lifestyle change, and others may unfortunately involve surgery, but there are answers.
Does the duration of symptoms matter? Say someone has had this, there are a number of people who are commenting and listening to the talk. Let's say someone has had this thing for more than 10 years compared to someone who's had this thing for the duration of maybe a year or two. Does it have an impact in terms of outcomes?
Not really. We are going to do the best therapy for you at that time. We're going to jointly decide. This is also a new day. We're long past the days when doctors dictated to patients. So the modern patient is more informed, And so we will lay options on the table, and then we decide together what is the best way forward. So the modern patient being more informed does not mean that you as a patient tell me what I'm going to do. You come with your knowledge, but at the end of the day, I must do that which is in your best interest. But it is not me dictating to you. We discuss options and we decide which one is most appropriate. So for sure.
There you go. It seems there's a solution for everything, but what is important is to get to the cause. The most important thing, since we're talking to communities, people tend to have solutions, any traditional solutions for some of the that we've raised. Urgency incontinence, stress incontinence, total incontinence. Are there any traditional remedies that you can recommend to people that you've actually seen in the region as an academic?
Sure. No, unfortunately not. I'm not aware of anything. Well, there's my background coming off again. I'm not aware of anything. However, like I said earlier, the scope for research, Afrocentric research, is big. And it's something that we need to be getting into. And I know that a lot of the people in the plant sciences are beginning to look at some of the traditional stuff that we've been doing all these years. What is the value? And so for sure, I think this is another potential area of massive research, but unfortunately, I'm not aware of anything in particular. Dr. T, are you there?
In summary, sithetha ngengxaki zesinyi, ingxaki zesingxobo sigcina umchamo, where people cannot control umchamo. Ugqirha has actually defined into yoba ingxaki zisenokwenzeka uba zikwesi sihlunu sigcina kwesa singxobo sesinyi, okanye ingxaki zinoba kulaa valve, le nto sithi si-sphincter, le ixelayo into yoba umchamo mawume ngoku, umchamo mawuqhubeke ngoku, okanye ingxaki inoba kwezi zihlunu zilapha kumgangatho lo wesinqe, ezinto sithi zii-pelvic floor muscles. Then kubekho iingxaki zento yoba mhlawumbi umntu wayelimele, ekulimaleni kwakhe angakwazi ukukhontrola umchamo ngenxa yobuxhakaxhaka, ezinto sithi zii-nerves, utywala osubuselayo, utshaya, and icaffeine, le nto igalelwa apha ekofini, inako uba nomthelela ekukhontroleni umchamo. And then waphinda wayichaphazela into yoba kunobakho i-confusion okanye ingxubakaxaka xa umntu engaxilongwanga kakuhle, ukubhidanisa laa nto kuthiwa si-squirting notaka komchamo during i-process ye-intercourse. Wachaphazela into yoba inako ukuchaphazela abantu ekuzithembeni, ibhinqa linako ungazithembi ngenxa yoba umchamo umntu omdala uyanuka. So uba umntu uphuncukelwa ngumchamo throughout the course of the day, kunobakho ivunjana elisuka apha ngaphantsi, okanye funeka atshintshe ipad. Nendlela yophangela, wedwa wenza umzekelo ngegqwetha elithile eliphangelayo, funeka limane lisiya etoilet every 15 minutes, emane eyochama. So laa nto inako ukuphazamisa indlela ophila ngayo nendlela ophangela ngayo, ngoba funeka ubale into yoba funeka ndiyochama ngexesha elithile, kufuneka ndingayochama ngexesha elithile, then xa ndiphuma endlini funeka ndiqale ndithi make sure into yoba ibladder ndiyi-emthile, njalo njalo. So kwindlela oqhuba ngayo ubomi bakho ine-impact nokuzithemba kwakho, but uthi ke ngoku zikhona indlela. Into ebalulekileyo kuba umntu aphakame. Problem abantu bakuthi kungayixeli into yoba ndinengxaki yokukhontrola umchamo, okanye ndinengxaki yophuncula umchamo xa ndihleka okanye xa ndikhohlela, okanye oko ndathi ndabeleka umchamo wam awukwazi ukukhontroleka kakuhle, ndibona sele ndimanzi. Communication xa uye kwagqirha mawungabi nzima uthetha ngezi zinto, sizokwazi undidibanisa neengcaphephe ezinjengoDr Mathabe. Enkosi kakhulu. Doc, are you back? I was just doing a summary. Yeah, I was just doing a summary.
Thank you. I was with you.
Yeah.
I was with you.
because we lost a bit of sound on you. You were still tackling my last question. Can you just finish it off? I don't think we heard you properly.
What was it?
What did I ask you? I was asking you about solutions. We're in the solutions category. In terms of solutions, you said you do inject some things directly to the bladder, toxins to the bladder, and then there are drugs, and then there are operations to lift the bladder. And then we talked about duration. We're on the issue of duration. If someone stands up after 5 years and versus someone who comes out after 10 years, you said there's no difference. What is important is for a person to actually come up and tell the problem. Any other advice?
Absolutely. You just, wherever you are in your process with this problem, raise your hand and seek help. It does not matter how long it's been.
Are Kegel exercises effective in addressing incontinence? Kegel exercises and squatting, how effective are they?
Still there?
Yes. The impact of Kegel exercises and squatting, are they effective? Kegel exercise and squatting. People may say, I don't have money to see a specialist. What can I do in the meantime?
Absolutely, those are effective. And we're living in a time and an age where information is available. If one just Googles something or YouTube, one can find a lot of exercises that are available and they are effective. I mean, it's better if you've got a physio who can direct you through how to do this. But, you might not have a pelvic floor trained physio nearby, in which case, certainly you can do the exercises by yourself at home. And I mean, they're fairly easy to do. It is just about, like most things in life, unfortunately, it is about the consistency. It's about doing what you need to do regularly enough to get the benefit of the exercises.
And then on the issue of home remedies, we lost you on home remedies. Are there any home remedies for urinary incontinence? Uyichaphazeleke ugqirha into yoba the more usiba nabantwana, the higher the chances of having issues ze-control yomchamo. And wayichaphazela into yoba akho mahluko whether udeliver nge-cesarean section okanye udeliver nge-naturally. Akho mahluko in terms of actually chances of having the problem. So it means akho difference. But ke ngoku xa ufumene le nto kuthiwa yi-assisted delivery, laa nto uncediswa ngezikere okanye ngee-forceps xa ubeleka, then uthi ii-chances ziyenyuka zento yoba ungane incontinence. I think we've got the best picture again now. I think you are perfect. Can you comment on home remedies for incontinence?
Not really. There are things, like I said, it's all about the conservative measures. So the conservative measures are the things that I've mentioned before, but beyond that, there isn't really much. And that probably speaks to, my being, trained in medicine. So Western trained, unfortunately. So we do have the big gap about, there's a few things that we know we can do at home, and then otherwise it's stuff that's in hospital and it's pharmaceuticals and it's surgery and stuff. But that in between step is still a gap in our knowledge. So I unfortunately cannot comment on any home remedies really. Avoid the caffeine, lose the weight, that type of thing. That's all I can speak to.
Lose weight. Weight, the issue of weight and the issue of alcohol and the issue of smoking keeps coming up in most of the medical problems. Since we are in Women's Month, there is something that people always raise, that alcohol goes down in terms of females. You spoke of alcohol as a diuretic. And you spoke of alcohol as one of the probable causes of some of the problems we could be experiencing in terms of damaging nerves and so on. What message can you actually put across to the South African community, noting that on Monday, the bars will be open?
So
And
I can't say
smoking starts.
too much in terms of alcohol and the urinary system. But alcohol and our behavior in general is definitely a problem. I have a friend who's a trauma surgeon, and we do have a big problem. I mean, in there, a couple of weeks ago when the ban on alcohol was lifted for a short period of time, in that 1 week, we saw 4 alcohol-related urological trauma, including a gunshot scrotum. Yeah, so I mean, when we get alcohol in our bodies, we tend to be a little bit less rational in our behaviors. So it certainly is a problem from that perspective. Not so much from the urinary perspective and the incontinence perspective, but I mean, we see urological trauma related to the use of alcohol. So we certainly do get, we do bear the brunt of the use of alcohol that is irrational. Absolutely. And I mean, we know that with everything, we should be doing everything in moderation, right? So when we don't do things in moderation, there are certainly consequences.
And then you said smoking causes coughing. And then when you cough and then you've got a problem of bladder control, then you start making the problem worse. So smoking has a direct effect.
And another thing from a urology perspective that people don't necessarily appreciate, everybody knows about smoking causing lung cancer. That's an obvious one, we know that. And smoking being bad for the heart, ischemic heart disease, we know that. Smoking causes bladder cancer. This most people don't know. So the number 1 risk factor for bladder cancer is smoking. And the first way that we might recognize that might be that with the very early lesions that smoking causes in the bladder might cause irritation. So a patient might have an overactive bladder due to early bladder cancer due to their smoking. And that's why I say if you're unable to control your urine, you need to see a doctor, because it might be nothing. It might be something so simple, but it might be something as serious as the early stages of a bladder cancer. So for sure, smoking can impact on the bladder and the urinary system.
You mentioned, we are left with a minute or so. You mentioned urinary tract infections as contributing to more females getting a high level of infection than males. Yes. Is the difference, is this caused by the difference in the length of the ureters or what in males and females? Why are females prone to?
Absolutely, that is the most common reason. There's other things that contribute, including the estrogen levels, as I mentioned earlier, but the biggest reason. So the microorganism that is most responsible for bladder infections, for the majority of bladder infections, is E. coli. And E. coli comes from the gastrointestinal tract, so that comes from the anus. And the distance between the opening of the urethra and the anus in women is so much shorter, placing women physiologically at a risk of bladder infections for sure.
And then lastly, you mentioned the prostate as contributing to control of urine. And then it means men have got an advantage of having a prostate in terms of urine control. As much as we will, as we go ahead, we'll prove that it may also be a problem to have a prostate. And then you mentioned that females don't have a prostate, they just have remnants of what was supposed to be a prostate. I'm looking forward to our next discussion where we'll be sitting on the prostate, the prostate gland. We'll be looking at the prostate gland in various angles, and then its functions, normal functions, problems, and issues that may actually affect the prostate. I know you've got special interest in the bladder and the prostate. That's why I'm pursuing your interest. And it's a woman's math. I'm gonna walk along with you.
Absolutely. I look forward to talking
just
about
shoot
that as well.
thank you so much. Can you then throw your closing remarks, messages to our viewers?
Messages to our viewers is that there are so many things that are not normal that we're not meant to learn to live with. And maybe just have a conversation with your doctor. You know, they might tell you that unfortunately you do have to learn to live with it, but a lot of things we don't actually have to learn to live with. So get a medical opinion on that.
Thank you so much. And then can you comment on toilet training? We've got young girls and so on. What can we do better to better the chances of avoiding this?
Toilet training for girls is a very interesting topic. That's a whole hour of conversation. But toilet training for girls in the cities. So the best way to toilet train a child is actually let them pee, you know, out in the field or in a bucket. The moment we start putting little girls on toilets, on the porcelain toilets that we have in the cities and stuff, we start a whole range of bladder problems with that. So there are things that we need to do if we're going to be potty training our children, our female children, on toilets, for sure. The simplest one being that they must have a footstool. When somebody pees, their feet must be flat on the ground. So that little footstool for the toilet is the first step in avoiding a whole bunch of problems.
That's a nice tip. I'll take you on that. In there, you say it's a whole chapter. So it means we've got another chapter that is to come. Dr. Matabe, let me thank you very much on behalf of Apile Communications and on behalf of our viewer community. You've delivered a very handful of lessons, and most of them, I'm sure you'll have time to go through the comments through our YouTube channel and through our Facebook page. You've done a very wonderful job, not only for us, but for South Africa at large, because these lessons will actually stay forever on our channel. We are very grateful to have academics like you who are very easy to reach, especially a rare species like a female urologist. I'm very grateful to have landed you on our channel because you have actually broken a lot of ice and defrosted a lot of females to know that the male organ is there for everyone to handle, especially academically. And also you've broken a lot of stereotypes to prove that there's no male or female things. We're actually thinning the barriers, which is our agenda as Apile Communications. Thank you very much for your time. We appreciate your effort and we appreciate your simplified lessons on control of the bladder. And our people now know that the sooner we address these problems, the better. They are as common as flu, and most of them are solvable because they are specialists like you. And people must know that it's not easy to just simply jump and see a specialist. There is a ladder that you follow from primary health care to secondary, then to tertiary. Then most of the problems will be addressed before they affect our self-esteem. And let me encourage people to actually subscribe to our YouTube channel, is Apile Communications, and follow us on our Facebook page, which is Apile Communications. A lot is still to come in our health dialogues with brains of South Africa. Thank you very much, Dr. Matibe. We call it a day.
Thank you. Thank you, Dr. Tebelele.